Hi, today we're going to be covering population health for nurses in the OpenStacks textbooks. We're going to be covering chapter 12. This is epidemiology for informing population and community health decisions. So as an overview, we're going to define epidemiology, look at it from a historical perspective, think about these different approaches, types of study designs, epidemiological measures, and communicating inference from epidemiological data, and the role of epidemiology in scientific discovery and policy. So just in this first part, by the time we're done here, you should be able to define epidemiology and then explain the objectives and also the role in public health. So epidemiology is the scientific study of the distribution and determinants of diseases and health outcomes in populations. And this is to develop methods of controlling health problems, limit consequences of illnesses, and maximize health. Really, it's multidisciplinary, so this is the basic science of public health, and it seeks to establish causal factors of health events. So identifying cause or factors that increase risk of contracting disease, this is really the heart of epidemiology. So it's identifying really where is this transmission occurring in a specific population and evaluating preventative and therapeutic measures of healthcare delivery. So we want to look at the foundation for developing public policy in disease prevention and health promotion. So nurses are using evidence-based information and interventions all the time, and these help reduce morbidity and mortality. So appropriate control mechanisms really can be identified in epidemiological studies, and we're looking at the prevalence, so how common is this problem and the extent of the disease in the community. And health promotion is on this foundational level where we're thinking about how can education be used to promote these evidence-based interventions. So now you should be able to talk about the history and origins of epidemiology when we're done with this section, and then think about who are the key people in the field who contributed to epidemiology historically, and then examine really the contribution that nursing had to the field. So when we think about the origins, we're going to trace this back to the physician Hippocrates, who on Airs, Waters, and Places in 400 BCE's textbook looked at disease caused not by the supernatural but the environmental factors. Edward Jenner was also monumental in he lived from 1749 to 1823. He developed the immunization against smallpox that eventually eradicated the disease. In 1846, Ignatius Semmelus was specializing in obstetrics. He theorized that postpartum mortality was higher where physicians and students performed autopsies before caring for women in labor. So then he instituted hand washing, which brought the mortality rate down. When he was replaced by another physician, the hand washing was abandoned and the mortality rate rose. Also, there was British physician John Snow, who lived from 1813 to 1858, and he was really often considered the father of the field of epidemiology. He translated epidemiological observation into public health policy in the 1850s. And then Florence Nightingale was the first nurse epidemiologist who used statistical methods to visualize data and bring about health reform. And here's this picture of her. So the lady with the lamp, she worked tirelessly to care for soldiers during the Crimean War, and she would make rounds on them, and she really looked at their environment. Were their sheets clean? Were the windows open to help prevent the disease from spreading? She didn't really know all of the information, but she knew that she could help with these patients and keep them from getting worse or spreading illness by keeping the environment clean, which was actually instrumental in that time. And she used data to do it. She'd say these people versus those people are getting more sick. Okay, so this next section, we're looking at approaches. So agent, host, environment in that epidemiological triad. And we're going to talk about communicable disease transmission, explain this natural history of disease, and look at the chain of infection and the web of causation. So this epidemiological triad, it poses that disease can be caused by an interaction between a susceptible host, external agent, and the environment, bringing that host and agent together. So the host can be an individual, family, group of high-risk individuals, or it can be a community. And the agent is something that can cause a health issue. So the environment is the context in which the host and agent interact. And the environmental factors include biological environment of plants, animals, toxins, including vectors, life forms that carry infectious agents, and the reservoirs where vectors and infectious agents are usually found. So here are the 4 stages of that disease progression that we talked about. So you're looking at that stage of susceptibility, and then now we have an exposure. The person is exposed, and let's say they have that virus. Now they have this subclinical disease. So, right, they're not showing symptoms yet. They're pathogenic stages. Now they're showing these symptoms, and that's when they're usually diagnosed, is when those symptoms are really in full force and showing, and then they start to get better. This epidemiological model, it allows for more complex and nuanced interplay between this host, agent, and environment of that triad. So we can see the reservoir where the causal agent normally lives and reproduces. And this can include the environment, humans, and animals. That portal of exit from the reservoir, this is how the agent leaves its home and becomes an agent of transmission. We're talking about the mode of transmission. This is where diseases can be transmitted directly or indirectly. The portal of entry is how the agent infects the susceptible host. It must provide contact with tissues, and the host is a key component in that final link in the chain of infection. And the host susceptibility depends on multitude of genetic and non-specific lifestyle factors. So here we're looking at this web of causation. So in 1960, the web of causation became this epidemiological model to demonstrate this concept of multiple causation in the health and illness spectrum. So this is describing just all the different factors that are related and may underlie chronic disease. So then this next part, we're going to talk about study design. So differences between descriptive and analytic epidemiology. Talk about the purpose of experimental studies and the purpose of observational studies, and discuss different types of observational studies, and then also think about interpretation. There are 2 main branches of epidemiology, and this is very important to us as nurses because a lot of PhD nursing will start in this descriptive area. So looking at person, place, and time of health events. A lot of pharmacology research in terms of looking at what drug therapies are being invented to save people from cancer are in this analytic arm. So this is looking at the why and how diseases by testing a hypothesis of causal relationships. So causal is what is the thing that is making this disease happen, whereas the correlation could be the things that are associated with it. And when we think of descriptive, this is really looking at who is having that, the population, right? And there is a big push on this causal relationship. The causal, knowing the cause is the thing that wins the Nobel Prize. I think in nursing, we're well positioned to be translational scientists because we can look at both the cause and still look and care about the correlation. Why? Because we are with these patients all the time, and knowing them makes us more attuned to all of the factors influencing them, and then it can lead us to better ask the question that can discover the what is causing this to happen. So just an important distinction there. There are different types of epidemiological studies. So normally you have to have two groups. One needs to be the control. So we're looking at, say we're examining disease, then the other group is the one that doesn't have the disease. So analytic epidemiology studies, they're experimental or observational. So experimental studies, this is really known as intervention. If they're well done, they're typically considered the gold standard, right? So this is where you can think of it in terms of bench science. You have, your clinical trial, or you have your, like I said, your control group and your experimental group. You have it randomized typically, unless it's quasi-experimental, and you're saying, if I put this in here, then what happens, right? And so you have to test it, and then you keep testing it until you can find, the why. And observational is looking at exposure. So this is often done by, you can think of it like, okay, we're going to get this big data set, and we can look at all this EHR data for the last 5 years, and we can examine those who have all come into the ED presenting with a cough, look at those who have lung cancer and those who don't, and then examine the differences. So we're observing the data. We're not doing something to a person or an animal as an experiment to test our hypothesis. So we still have our hypothesis, we're still testing it, but it's not done in the same way. A cohort study, this is observational. We're looking at a group of individuals and we're trying to say, okay, do they share a characteristic? So it could be a group of pregnant individuals. That could be a cohort study. Case control, this is where investigators can enroll a group of individuals with the disease in a control group of people without it, and then compare previous exposure. So you're really looking at exposures of disease in this case control. And then for cross-sectional, this is where we're looking at a population and we're measuring their exposure to something to get a snapshot. So this is typically done at one point in time. So if you think about deploying a survey, right, once, then that could give you that cross-sectional information. Or if you're doing a study and you enroll people to come in and you get their biometric data, but you're doing it at a specific one point in time, again, that's that cross-sectional. So here, what we're looking at, this is just showing, a picture of someone doing an experiment. So we're thinking about randomized controlled trials again, right? That's that gold standard. That's experimental. We have a control group. We're testing our hypothesis. We're saying, is it what's happening when we put this intervention in? And then we're testing that to see if it just happened by chance, or if it was the result of our experiment. So we want to know as researchers whether or not this causal relationship exists between an agent or exposure and a disease. Again, the main thing here we're thinking about is causal. So this is the first question. Using a comparison, a causal relationship exists when that agent or exposure. So think of this in terms of cancer, right? So you have a gene, it's exposed to whatever is triggering it, and then now is that cancer occurring more frequently than the baseline? So it's one possible explanation for when we're thinking a causal relationship, when we're looking at this, we want to know, like we said, the why. We're looking at observed relationship. It's not proving that it's there, but it's showing an association. So it can be that comparison. It allows for future analysis. It gives us that baseline. It helps us to refine our research question and to have more effective interventions. We're going to talk about now disease occurrence in a population. Think about it in mathematical terms in epidemiology. Describe different measures to define and quantify health. Look at these analytic methods and also possible sources of error in epidemiological studies and criteria to look at causal relationships. So endemic, this is continual and constant presence of a disease within a geographical area. Hyperendemic is persistent high levels of disease in an area. Sporadic, it's occurring at irregular intervals. An epidemic, all of a sudden we see this sudden increase. And then an outbreak is an epidemic that affects a specific geographical area. And a pandemic is a worldwide epidemic. So when we think about ratios, we're comparing any two values by dividing one interval by another. So this can be used as descriptive. Also, it's used in calculations for the occurrence of illness or death between two groups. So proportions, this is a form of a ratio where numeric represents a subset of the denominator. And rates, this is what you guys have been looking at. So in epidemiology, a measure is how often an event occurs in a specific population over a specific time. And then morbidity, this is what we call when you're having a disease or illness or medical condition, and mortality is the frequency of death. So when we're looking at measures of association, we want to assess the degree to which the risk of that disease increases when it's exposed to an agent, or the strength of the causal relationship. So when you're reading these studies and you're looking at the data, you're going to see something called the relative risk. And if you get your PhD, you'll do this. This is also known as the risk ratio, and it's comparing the risk of a health event among one group, and it's looking at that risk of another group. And then the rate ratio, this is really looking at the incidence, the number of new cases or rates or mortality rates of two groups. It's usually differentiated by exposure to a suspected causative agent. Then the odds ratio, again, this is used in a lot of studies. You'll see it reported in all of those figures and graphs. And it's similar to the rate ratio as it's quantitatively expressed in the association between an exposure and a disease or health outcome. So most often it's used to estimate the risk ratio in a case control study when the disease is rare. So it's important to be aware of these in these different settings. And then attributable risk, this is often used as a measurement of risk, representing the amount of disease among an exposed individual, and it's attributed to exposure. So it represents the maximum proportion of disease that can be attributed to the exposure and the maximum proportion of the disease that can be possibly prevented by eliminating this exposure. So we're looking at these epidemiological studies to understand this, and then that translates to our surveillance data, that translates to our public health policy intervention, and on the public health nursing levels, as well as if we're doing research in these areas. We have to always ask, what's the error? So could it be a positive association discovered between an exposure and a health event when there really is no association? Or could it be that there's no association that's found between an exposure and a health event when there really is something there? And chance, like sometimes there are random errors that occur within a study. The p-value, this looks at the probability that the observed association could be the result of random error. So when you see it significant, right, so the p-value is significant, then that means that finding is most likely not due to error, right? And then bias, this is referred to as a systematic error. It's another type of error arising by the design. maybe the study wasn't conducted well, or the data wasn't collected well, or the analysis was done incorrectly. And then co-founding, this happens when there's another factor that's mistakenly identified as the agent associated with the outcome. So if you're not doing causal and you're saying, okay, these things are associated, then it could be mixed up. And that's why they're saying it's more common with observational studies than experimental. So establishing causation, this looks at an increase in disease incidence among exposed patients or subjects that would not have occurred if these subjects had not been exposed. So what is the reason they're getting this, right? And then epidemiology cannot prove causation, but causation can be inferred from the data that is being analyzed and interpreted. So after errors like chance bias or confounding are ruled out, then we can use these 9 factors and criteria to make these judgments about causation. Now we're going to talk about these applications to public health and how we can improve it. So in nursing, right, we're at the heart of the community, and we use evidence-based practice, and we create evidence in our research, and this is used to then be translated into these patient platforms. So we're educating the public, and when we talk about research translation, we're talking about taking this scientific research and applying it to a practical setting. So currently I'm doing cancer research. We're going into the hospital in a couple of days to interview patients and oncologists to see how is our research going to be implied or implicated in the setting, but also to get that feedback from the very early genesis of where this is being done, which is extremely important. That to be able to translate it means to have these key stakeholders involved from the very foundation of our research questions. And then when we think about health promotion, we must understand research, understand what we just talked about, what's the difference between experimental and observational studies. That way we can explain what these evidence-based recommendations are to our patients. That way we can be the people who are conducting this. And we have to do good science. We have to have rigorous quality for the science that we're performing. And we have to understand how to interpret that as well, and then be able to communicate that to the community. And that's where we have trust and credibility, and we are able to be the people who can inform the public and lead them into safe health practices, or even understand why they're not engaging in them, and just be there for them so that we can hopefully improve their health for the better along the way. So we're going to talk about scientific decision making, policy making, and the 10 essential public health services. So when we talk about the foundation of scientific decision making, we're really thinking about how clearly is the scientific evidence presented for public acceptance. So the U.S. Preventive Services Task Force, this is an independent organization of national experts in disease prevention, and they make evidence-based guidelines. We think about lung cancer screening, right? This is using the USPS TF guidelines. So how is this is then translated to reimbursement, right? So the insurance companies will reimburse for screening based on these guidelines, right, that then are being used in clinical practice. So we have to be able to be doing the science to say, are these the best ways to screen, to inform these guidelines that will be translated then to patient care, and hopefully then improve the earlier detection and prevention of lung cancer. So the goal is really to improve nation's health by making these evidence-based recommendations. We're looking at rates of preventative services. And the Agency for Healthcare Research and Quality, this is another organization that uses epidemiological research as a foundation for clinical practice guidelines. So there's evidence-based practice that's centering on these reports and is looking at medical conditions, how much do they cost, what are new technologies. And then the Framingham Heart Study, this is the largest running prospective cohort study in the United States. And the findings are now common knowledge, but they weren't when they were done. And that's smoking, high cholesterol, hypertension, and obesity are common characteristics of people with cardiovascular. So the basis for policy development, its intentional practical applications of studying epidemiology really affect population health through primary and secondary prevention. So one example is policy development in youth for tobacco control. So when we think of this on an individual approach, we're looking at how this changed in favor of population and how putting these laws out by not smoking within a certain distance, having taxing on tobacco products, and then decrease this rates, and then discourage youth from smoking. And then that has to evolve now with vaping, and will probably constantly have to evolve. And then when we think about this intersection of the 10 essential public health services, so these are activities to help communities be healthy. So the first is really investigation and monitoring. So that's, we're thinking about surveillance data, and then policy development. How is this helpful in terms of vaccine policy or smoking policy? And then insurance. So are we doing things to evaluate, are these still the best policies? Are they working? Are they really improving health? Thank you.